Welcome, everybody. I know that many of you are still getting your lunches and sitting down and saying hi to friends and family who you haven't seen since last year. Welcome. This is the REILS talk, and today we're going to have representatives from the Indiana Health Information Exchange tell us about what they're up to, where they're going, and hopefully give you all a better sense of, for those of you who aren't super familiar with them, a better sense of what's going on with IHIE. We have two speakers. The first one is John Kansky. John is the CEO of IHIE, the Indiana Health Information Exchange, and the second speaker is Drew Richardson, who is the newly minted Chief Operating Officer for the Indiana Health Information Exchange. So without any further ado, take it away.
Hello, and thanks for the opportunity. It seems like IHIE comes and offers a talk to this group every couple of years at least, and we really look forward to that because as I've said to Dr. Patzer and Dr. Granis, it's like we can never communicate enough, so more is better. So appreciate the opportunity to be here. Oh, before I move on from my title slide, I was showing these to Sean the other day, and he's like, what ecosystem? And it's like, I promise I will explain what ecosystem. We have no conflicts that would get us in any trouble, but I am told I need to show you the slide. Things that we're going to cover today is a brief recap of the Regenstrief IHIE history. Dr. Tierney can correct me if I get anything wrong. But this is always a place I like to start because I've been told, I was called an elder statesman the other day, and I guess that means old. But I don't want to skip over some of the history and assume everybody in the room is aware of it. Learn about the present state of the health information exchange ecosystem, review the key drivers in what's compelling IHIE strategy these days, or more specifically, maybe compelling us to change or adapt. And then discussing some existing potential Regenstrief IHIE collaboration opportunities. And at some point in the presentation, I'll hand off to Drew, who will cover those things. So what's up with going on at IHIE, or what's happening in our ecosystem? So let me start to set the stage for that with some relevant history of our collaboration. So the Indiana Network for Patient Care, or INPC, as everybody calls it, really started in 1994 and was launched by Regenstrief with hospital systems in the Indianapolis market. IHIE did not even exist for another 10 years. So in 2004, the Indiana Health Information Exchange was founded with the involvement of Regenstrief and some other important healthcare and business entities, largely in central Indiana. And pretty much just based on the Docs for Docs application. If you don't know what Docs for Docs is, don't worry about it. But that was an application that was conceived of and developed here at the Institute, and IHIE was sort of created at that time, over 20 years ago, to be the business entity to deliver and support and, dare I say the S word, sell that to the marketplace. In 2008 through 2012, and I have a slide for this in a second, there was really dramatic growth of the INPC, and I didn't want that point to be missed because it started out as kind of a small Indianapolis thing, and today it is absolutely a statewide thing. It's not just a statewide hospital thing, it's a statewide healthcare thing with a lot more participation from lots of stakeholders in healthcare. Also, well, I'm not going to explain it today. If anybody wants to ask questions about it later, that's great. But between 2013 and 2019, there was a real significant maturation of IHIE financially and operationally. And I asked for some headcount, some numbers on headcount, and we were, less than 50 employees in the about 2013, and we're over 100 now and have been since 2020, when we consolidated with the Michiana Health Information Network that was based in South Bend to become Indiana's own sole statewide health information exchange. That was significant. It might seem super obvious. There are still states that I'm trying to think of better words than suffer from. They're underachieving in terms of the value of health information exchange in their states because they have multiple health information exchanges. Not surprisingly, they're the most populous, diverse states: California, Texas, Florida, New York, all have multiple health information exchanges. It took 10 years-ish to get to the point that Indiana had just one statewide health information exchange. Okay. I'll go faster. This is, I promised to slide. This is the number of hospitals, and I regret that I'm using a hospital metric, but it was the one I had most conveniently available. That between 2007 and 2012, there was dramatic growth of hospital participation in the INPC. I don't have anything after 2012 because it got a little boring after that, because we had just about saturated the state. We're at about 123 hospitals now, which is, there's probably 128, 130 hospitals in Indiana. It really depends how you count them. It's harder to count hospitals than you might think. And also, this is just a quick view of, so blue represents the fraction of the population that has some reasonable amount of data in the INPC. And as you see how much we've been able to, and when I say we, I mean the big we've been able to build the INPC into a statewide, relatively deep coverage of the population. Also wanted to stress that Regenstrief and IHIE have leadership connections. Dr. Granis serves as on IHIE's leadership team as our Chief Medical Information Officer and official or unofficial liaison between the two organizations. Sean's kind of always my go-to in terms of, hey, explain this to me, or can you make sure that the team at Regenstrief is aware of this or that. I serve on the Regenstrief Board of Directors, and speaking of Dr. Tierney, that is credit to him that he helped make that possible many, many years ago, that the CEO of IHIE would serve on the Regenstrief Board of Directors, and they haven't kicked me off yet, which I must be behaving myself reasonably well. And then Dr. Patzer serves on the IHIE Board of Directors, and the CEO of the Institute has, as long as I can, I think, always sat on the IHIE Board of Directors. Okay. Shifting gears a little bit, this is the slide where I want to spend actually most of my time. I've got some sections on the change. This says HIE ecosystem. I really want it to say National Health Data Interoperability Ecosystem, but that doesn't fit. But HIE and that sort of label is increasingly way too narrow. The ecosystem in which our organization operates, maneuvers, has to remain aware on a state and national basis is health data interoperability. How do organizations, how does the healthcare system, how does research, how does business get and exchange and interoperate with regard to health data? That's so much more complicated, crowded than it was when I started with IHIE 20 years ago, or however long it's been. Let me spend just a moment on that, because really, I kind of not, these are the things that are moving our ecosystem. Or yes, sir. Please.
Why is all this stuff? To drive our research, we need information data to need systems to capture that data. The health information exchange here is incredibly unique source of data that's unlike most other places in the country. That ecosystem is evolving. John's going to tell you how it's evolving. I think it's important as investigators, as staff, that you understand how the lifeblood of our work and the systems that it's being captured and governed by are evolving. I think it's super important to this organization that we understand that. Over.
Thank you. And some of this, if you're on the scale towards the HIE dork side, where I sort of peg the meter, some of this is going to make more sense, and some of this is going to be a little nuanced. So trying to hit the center of the audience, but where I was just, and thank you for clarifying, because it helped me gather my thoughts. One of the things that may help explain this, when I started at IHIE in 2007, you could get up every morning and just worry about what Indiana cared about, the Indiana hospitals and the big hospital systems. If they were okay, you were okay. And I'm going to throw out some buzzwords or acronyms that you may not be, but between the ONC and TEFCA and Care Everywhere and Commonwealth and eHealth Exchange, there's just we have to I have to pay much closer attention to national trends, national politics, national policy, and state policy and state politics than I ever had to in those days. And it's all so that we can maintain a health information exchange that continues to feed more and more diverse, deeper, and higher quality data to the INPC to support healthcare, but also to support research. That's whether this is, I literally have a sticky on my monitor at home that says, it's the INPC, stupid. Because that's really what has to be, that's the center of how we produce value. And that's the data asset that has to maintain to be healthy and move forward for everybody to benefit. So what's influencing our ecosystem is consolidation among health information exchanges. I don't know, Dr. Mark Overhage was once upon a time the CEO of IHIE, as well as being the director of CBMI here at the Institute. And he and I used to talk about the fact that being a small HIE is bad. It's economically unsustainable. So HIEs, being the only HIE in Indiana, is helpful to IHIE, but there's increasingly health information exchanges that cover multiple states, Nebraska and Iowa, Arizona, Colorado. The CRISP in Maryland covers several states. That's a trend. Cooperation mostly among large health information exchanges. There is an organization that IHIE founded with 5 of the largest, most capable HIEs in the country called the Consortium for State and Regional Interoperability. Do not write that down. I think it's a terrible name. But CSRI is an organization that allows us to collaborate very closely with the other large HIEs that cover several states. And frankly, we end up being sort of political, small p and large p sometimes, leaders. We were invited to a meeting at the CDC. There was like 5 HIEs invited to that meeting, and we were one of them. And it's good to be at the table when they're making policy. Emergence of the health data utility concept. This could be an entire talk, but suffice it. Let me try and explain it this way. Most people, if they understand what health information exchange is at all, they're thinking about, oh, that's how a doctor gets information from another place to help support the clinical decisions they're making for direct patient care. And that's true. It's always been true, and it's true today. But there's so much more diverse needs for health data to be shared, aggregated, normalized, enhanced to support employers and their management of their workforce, or payers and manage for quality measurement or care management, for policymakers. And there's health systems participate in ACOs that require them to manage populations, and all that requires the exchange of healthcare data. At some point, you can, so IHIE believes itself to be a health data utility for Indiana. not a perfect one that still has gaps to fill, but most large established statewide health information exchanges are now following a health data utility model, which is just a lot more diverse in terms of its segments that they serve, value propositions that they offer, data that they exchange. That's health data utility in a nutshell. I'll talk about that in a second. Epic market prevalence. 10 years ago, health information exchange leaders would complain that they couldn't do more information exchange because electronic health record vendors were incapable. They didn't have their platforms were not built for data interoperability, or the standards were immature, or the federal government really hadn't had policy to embrace it. But it was really, they complained that electronic health records could not exchange data more better. Then one day they started complaining that the electronic health records were creeping into our space because they were getting too good at interoperability. And I would wave my finger at my peers and say, you cannot complain that the electronic health records are not good enough and then complain that they're too good at interoperability. So Epic is a world-class electronic health record platform, and all electronic health record platforms have been compelled through the market and through federal regulation to be much better at data interoperability. And the fact that a predominant number of large hospital systems in Indiana, frankly, most states, will be on Epic, and they will be using the capability of the electronic health record to do especially point of care interoperability is a factor in figuring out how the Indiana Health Information Exchange continues to complement, enhance, add value in a world that will never be all Epic, but is getting better. Technological platforms are getting better at interoperability than they used to be. Back in the day when, and I'm going to make this statement, that the Regenstrief Institute invented the concept of health information exchange, which is not something most people say, but I think we can defend that, is the way I put it is like they woke up one day in the 90s and said, these HL7 standards are good enough that we can exchange data between electronic health records. That was, or whatever systems held those. That was groundbreaking in those days. We fast forward, that continues to change in today's world. TEFCA is, if you don't know what TEFCA is, don't worry about it. You don't need a lesson in TEFCA, but it is a government-endorsed voluntary approach to exchanging information, and the words stand for trusted exchange and common agreement. I mostly find myself explaining away the expectations or perceptions of TEFCA more than the realities of TEFCA because it's nascent, but that's a factor in our world. And then to a lesser degree, expectations of the use of API and AI, which is kind of everybody, but I threw it in there. Okay, box number 2. What are the things that are driving our strategy today? And then again, I'm not explaining our entire strategy, but I thought it might be telling to explain what are things that are big enough that they're causing us to think about how do we need to be different. So I talked about health data utilities or as a model or as a concept, and the fact that we now view ourselves as a health data utility. The federal government has taken an interest in the concept of health data utility, and I can explain that pretty concisely. It's going to sound kind of negative, but frankly, federal policy on health data interoperability has largely disregarded health information exchanges across administrations, across political parties. It's just that they, because they would wake up and they would see not every state has a good health information exchange, they sort of leapt to, so we can't rely on them, so we just have to do other stuff. We have to do point-to-point connections via electronic health records or something. So we were disregarded. More recently, with the emergence of the idea that every state could and should have a capable health data utility, the federal government is now entertaining the idea of, well, given things haven't really worked well or solved all the problems with our previous attempts. What if we did place a bet on or rely on state-based exchange infrastructure for what we needed? So that's could be a game changer for us. Number two, changed environment for multi-state partnerships or mergers and acquisitions. This gets a little bit to, remember I said that HIE consolidation was a trend. Before the federal government's engagement on health data utility, we didn't really have to think about, was the federal government going to herd the health data utilities together into groups and ask us to do things, or what was the federal government's policy around state-based infrastructure going to be, because there wasn't one. And so you're kind of on your own for, hey, Ohio, you want to do something together? We need to, be bigger, or maybe we could have economies of scale, or we Indiana Health Information Exchange proposed on Ohio was not exactly a fake example, but I'll give you a real one. The Kentucky Commonwealth government, because it's technically not a state. You learn that here, a cocktail party trick. Kentucky is a commonwealth. They put out, they were looking for a partner to run their health information exchange, and we proposed on that. We did not win it, but that's an example of that. It might surprise you a little bit, multi-state HIE. But now it just feels differently with the federal government engaging and maybe expecting each state to have one of these. So it's not a good explanation, but trust me, it's starting to feel different. Then the epic market prevalence we have to respond to and adapt to. And then finally, our state relationship is really, really important. IHIE has, Sean mentioned that there's a little bit where it's a unique HIE ecosystem in Indiana. We are less involved with, less supportive of, and have less of a active relationship with our state agencies than we would like, and certainly less active and less funded than it is in other states. So very important to us that we continue to build and foster that relationship with state government. Drew is going to talk about the Rural Health Transformation Program in a second, but that really offers us an opportunity to strengthen our relationship with state government. And then finally, third box, this is a little bit things you might want to know about IHIE. If you know Keith Kelly, who's been with IHIE almost as long as I have, he's planning his retirement in May. And because of that, we're making leadership transitions. And Drew, as of the first of the year, is now serving as our Chief Operating Officer. And if you know Brian Lawson, he's now serving as our Chief Technology Officer. All right, let me pass the baton to Drew, who's going to talk about opportunities and potential collaborations.
All right, good afternoon. I want to talk a little bit about the Rural Health Transformation Program. I know it's been in the news lately because Indiana was awarded $206.9 million, but we'll round up. $207 million for the first year. So this is a 5-year program that states are being awarded. I think through the big, beautiful bill that there was $50 billion that would be placed for rural healthcare improvement across the state of Indiana and then across the country. IHIE was asked to submit a proposal in November timeframe. This all came together very, very quickly. We were asked by FSSA to submit a proposal. We put together a proposal that was placed for Family Social Services Administration, but also was collaborated very closely with the Department of Health. So there's a lot of state agency collaboration that is happening. 2 of our board members, Dr. Weaver and Mitch Robe, are both on the executive oversight of that, as well as Dr. McGill and Dr. Wright are on a state-formed work group. So we had a lot of collaboration to ensure that what we were proposing wasn't out of thin air. We were trying to ensure that it fit with what the state was looking to accomplish within the Rural Health Transformation Program. There are 12 initiatives. There's an initiative 3 that focuses on health information exchange, which is where IHIE put the vast majority of our information in our proposal. A little bit about what was proposed. We looked at connectivity in rural counties. So when we first started, we looked at the number of counties, and we put out for 49 counties. Fed that back to the state. They came back and said, no, we're taking a different approach to what we consider rural. And that rural county number increased to 64 counties. So we looked at local health departments, FQHCs, CMHCs, SNF organizations, so long-term care. So what we were trying to do is as you work with INPC data, you may know that there are gaps. There are certain areas in which we don't have complete records. We tried to go and look at organizations, facilities that are not necessarily commonplace to the INPC and try to fill those data gaps and data areas, not only with going across the board, but try to get some depth. So we have some FQHCs, but we don't have enough of them. So how can we get as much of that data as we possibly can that for you would make that more useful as well? It is not mandatory. So we are not expecting 100% participation. We hope that we get that, but that is not part of the program. So in our proposal, we expected 50 to 75% participation. That's going to fluctuate depending upon a whole bunch of different parameters. We put some boots on the ground as part of our proposal because we know that it's not just signing these facilities up. They're going to need help with technical assistance. They're going to need help with contract assistance. These are many small organizations that don't necessarily have the capabilities or resources. And so we want to put those people on the ground to help as much as we possibly can. A big component of the Rural Health Transformation Program was, how is this sustainable? There is funding for 5 years, but once that funding goes away, then what? So our key was trying to ensure that we could demonstrate positive ROI throughout the program so that it can sustain beyond that initial 5-year investment. Then the final piece was we looked at some optional scope. We looked at innovation, primarily focused on consumer access to HIE data, because that's a big focus in having access to that data, as well as if you read the Rural Health Transformation Program, it has AI sprinkled throughout the entire piece of it. So we offered to enhance some of the capabilities that IHIE utilizes with AI. That's what we proposed. There's a webinar tomorrow at 2 to 3, I believe, to figure out how this is actually going to happen. So we proposed a whole lot of things. There is going to be potential procurement that happens with this. There's going to be RFPs, RFQs, RFIs, all sorts of different components. We think that IHIE has a place in this. We have to figure out, based upon our conversations with Department of Health, FSSA, to figure out exactly what that looks like. This is a big, big deal if IHIE receives this work. We will need to collaborate with other partners, other external partners, with Regenstrief, potentially as well. So there's a lot of opportunity with this potential program. Some of the stakeholders in those 64 counties, this gives you a little bit of a rundown. Obviously, John was talking about the number of hospitals. There are hospitals that are not connected that we hope to connect, so we could enhance the number of facilities that we receive information from, the number of practices, local health departments, federally qualified health centers, community mental health centers, SNFs, so those long-term care facilities as well. So really trying to complete as much of that Swiss cheese that we have within the INPC as possible. And this is going to be my last slide, and then John and I'll kind of talk a little bit about some opportunities, but here are some state and federal opportunities that exist as well. In December, IHIE submitted a proposal for some enhancements to the all-player claims database. So it's a database that the state of Indiana created about 2 years ago through the Department of Insurance. They offered 3 different enhancements, a mobile application real-time data updates, and some external data sources. We did not put a proposal in for the mobile application. That's not what IHI's core services are, but the two other pieces were real-time data updates as well as external data sources, of which IHI and Regenstrief were named within that RFI. We have not yet heard back. That was submitted, I think, like mid-December. And so we should hopefully hear something back. That could also turn into an RFP. And so there could be additional information or collaboration opportunities that happen in the future. And then the final piece that I want to talk about is the Health and Human Services Health Data Utility Demonstration Project. We talked a little bit about some of the collaboration opportunities that exist, and Sync Health, which is the Nebraska HIE, has been awarded a contract to put together a multi-state project, of which they are looking at bringing on Indiana as a collaboration partner. We are trying to figure out what the specifics of that project are, what the timeline of that project would be, and hopefully we could coordinate some of those components with the Department of Health in the future. So looking forward to that opportunity if that moves to fruition.
So hopefully we're stimulating some questions because we're going to leave plenty of time for that. And wanted to end with collaboration, past, present, and future, something that Dr. Patzer and I talk a lot about, something that Dr. Granis and I talk a lot about, something that Dr. Dixon and I talk a lot about, is continuing to not just continue collaborating as we have a long history of doing, but how do we do more and do it in a smart way. So I'm going to hand off to Drew in a second, but being that I am the guy with the gray hair, I get the from the beginning explanation. And it is noteworthy, and don't get me, don't ever invite me to come back and just do a history of IHIE talk, because it'll be like 3 hours and everybody will be asleep. But it is kind of fascinating. In the early days, Docs for Docs, I said, if you don't know what that is, don't worry about it. Now I'm going to kind of tell you, it sounds, if you tried to create a Docs for Docs service, which is an electronic delivery of lab results, radiology results, discharge summaries, and frankly, any document you need to get to a doctor anywhere in the hospital and the healthcare system, doing that electronically in the 90s when Regenstrief built out this application was revolutionary. Now you couldn't even sell it because practices have come up with other solutions. But by virtue of the fact that it's sort of the de facto approach in Indiana, we're still doing that, and it's producing high value for hospitals. And that was something that, again, Regenstrief conceived of it, developed it, and Regenstrief, and IHIE was sort of created to sustain it, implement it, manage it, and take the calls from the lady who swears she didn't get her lab result and needs to have it faxed to her or whatever it is. So anyway, CareWeb, I think everybody is aware of, is still going. I have a great story about Dr. Clem McDonald, the father of all things informatics. That's a slight exaggeration, but I have tremendous admiration for him. And he and I served on a federal committee together not too many years ago. And he told me he had a doctor's appointment with a specialist at IU. And the doctor at one point in the appointment said, "Oh, let me check. I'll look that up in CareWeb." And Clem was like, "What? That's still around? I can't believe it." So he was like so happy, and it made me feel really good. So anyway, we have a long history of doing things together that produce value for the healthcare system, but also enable each of our organizations to do good work. I'm going to hand off to Drew for things that have happened more recently and could happen in the future.
Yeah, so more recently, these are opportunities that we've collaborated in probably in the last 5-6 years or so. IU Health, Regenstrief, and IHIE, through collaboration with Titus, pulled together the Health Dart application, CareView, Fire Hydrant, the 15 different names that it had to go through to finally settle on Health Dart. But that's a fire-based application that looks at the ER care setting to provide relevant information in a timely manner. So a very great application that's being utilized as IU Health today. And we're hoping to navigate that into more of our Epic-friendly locations across the state. We've done some work with dental data with Thankum as part of that particular project. And it's been really great to see a different care setting that we've not typically done. So dental programs have and need access to a lot of that healthcare data. It's not necessarily top of mind, but we've seen some great integration that has happened with that project. And then some opportunities that we look at for collaboration in the future today. We're always looking at data quality. We have a group of Regenstrief members and IHIE members that come together and talk about data quality and trying to have an evolution of that. What does that mean? What do we need? Where can we find new data sources? What data sources do we have that we need to go and get more data or different data that will make that more complete? Sean and I are having lots of conversations around AI. What does that mean? That can mean a variety of different things. So tools that IHIE actually has and leverages that have AI capabilities, or data that we supply to our customers that is curated in a way that makes their data and AI functionality happen more effectively. And then obviously we've talked and shown a little bit about rural health. I think there's a lot of opportunity with rural health and that particular large scale project where we can have some opportunities. We're waiting just to finalize and see some details, but I think some conversations will happen very, very quickly after that point. Questions, comments, concerns? John and I are happy to answer anything from internal or
Hi, Nicole Keith, IU Center for Aging Research. I've been around IUCAR for close to 25 years. And one of my challenges is I'm a behavioral researcher. I'm an exercise physiologist by training. And when I look at health information, there's not a whole lot of behavioral research that I can glean. And I'm wondering if there are any plans for the future, and especially since you talk about the big, beautiful bill and with the new Secretary of Health and Human Services, if there is any plan to start collecting data for prevention and health promotion rather than simply health outcomes, which are really important. I'm not being critical. It's just a question.
So a couple pieces that we are working on and working towards is within our rural health transformation program. One of the components that we looked at is a consent management tool to allow us to expand to some behavioral health sorts of information. So one of the challenges that we have as an organization is to manage consent is really, really hard and challenging to do so. And it's not something that IHIE has taken on in the past. So as part of our proposal, we did try to put that into our proposal. Again, waiting to see exactly what comes out of it. I'm hopeful. The other piece is we've been having some additional conversations with other organizations around social data because we know that that is incomplete and trying to expand those. So there's been a variety of different conversations, nothing tangible yet, but I think I've been here 11 years, and when I started, we were having many, many conversations. I remember sitting in meetings with Sean, and we were talking about SDOH data then and trying to capture that. We haven't accomplished it, but I think there's definite desire and interest in trying to do so more effectively than we've done in the past.
I'd just like to add that I think I'm probably overgeneralizing, but there's probably no data related to healthcare, and that's even creating a bigger circle that includes what people would call social care. There's probably no data that we would not be interested in adding to the INPC. especially if it has value for research and or supporting patient care. It has to be something people capture, has to be something people are willing to share, has to be there has to be sufficient standards that we can make it usable in the INPC. And the one that hurts the most is there has to be some economic reason for sharing it that somebody will cover the cost of that. So Drew's right, and Drew's very hopeful and optimistic, and I wanted to be bad cop and kind of say, sometimes it's just hard because all of those things have to be true for us to add a new kind of data to the INPC, but we are absolutely interested in adding all of it.
Yeah, thanks for the presentation, John and Drew. I have to admit, this is always one of my most favorite talks over the years, is yours. Yes, well, don't be afraid. So I wanted to dig into a little bit into the collaborative potential. As you guys know, my thesis is we could do a lot more with collaboration than we are actually doing. I mean, there are good examples, as Drew showed. But a couple of years ago, we had the series of conversations when Peter MB was here about the sandbox and researchers and students being able to trial things on IHIE data, INPC data. Drew, I'm not going to put you on the spot, but I will anyway. Drew led on that the sandbox actually was going to be a reality maybe this year. So you can tell us some details about that. But I think the larger context here is traditionally, there was this very close relationship between Regenstrief and IHIE, and that has generated a lot of the foundational innovations. But now we have a much bigger potential playing field. With the CTSI, for instance, we are using Atlas, the Atlas tool, to make INPC data available, accessible to faculty and students so they can actually see the data and query the data. And that's really exciting for CTSI. We're also currently working on getting Notre Dame and Purdue the same level of access that we have. It's mostly a VPN thing, it's not a big thing, but so then you will have many more eyeballs on the data and potentially interesting projects coming out of that could involve Regenstrief investigators. It could kind of involve some of us. But the key is, if you want to build software applications, with Health Start, we've had long conversations that is not, you guys are not positioned to experiment with software applications. You need to have something where you can make money with, and that's it, because it supports your business model. And fortunately, Health Start did that. I know you can disagree with me in a second because I'm almost done. What is your current view of this? When are we going to have the sandbox? When can we expand kind of our visions for really cool new functionality that goes beyond Docs for Docs?
And Drew, I'm absolutely going to ask you to respond to anything you want to say, but I have to just, I want to be careful with some semantics. We do not have to do things we have to make money in order to pay our rent. So we're a not-for-profit organization. We take our mission very seriously. In other states, with leading health information exchanges, 55 to 95, if not 100% of their funding comes from state government. In Indiana, we're lucky if we have a 2% year because we earned it through a couple of projects. So the state government gets incredibly frustrated with us when we're saying, yes, we would love to do that. Do you have money to pay for it? They're like, oh God, it's always about the money with you guys because you don't give us any money. Where are we supposed to get this from? So yes, sustainability and economics is an irritating aspect of our life every minute of every day. Okay. And then something that you said that's true, but I think very telling is we can't experiment with software applications. What does that mean? We'd like to be able to have more opportunity for innovation and stuff. What I think you mean is By the time it's a federally regulated, it's an application that sends federally regulated data into a hospital or physician practice on which life and death decisions are being made, and there are certifications that we have to respond to. We have a very tightly controlled market that our ecosystem that our products have to be into. So when there's a good idea, we have to figure out how to collaborate with the Institute in a way that we do that outside that ecosystem until it's ready to be commercially hardened and put out there in the context of that certification and federal regulation. Hope that made some sense.
The only thing that I would add is that I think if you look at collaboration, I think, we had COVID and it sort of took a lull for where it is. And I think this is the opportunity of, one, having this discussion. I know we're having a discussion right after this as well, that I think that we could start to build of what does that collaboration 2.0 start to look like in things like the sandbox and things like, how do we do innovation together needs to have a more formalized collaboration discussion around it. So I don't have details on the sandbox, but I think we need to have further conversations.
A couple of questions. One is that you described, and this more goes to John, you described number of hospitals. But those hospitals are part of, about 40 or 50 of them are part of 5 major health systems that also have affiliated outpatient practices. So what's the degree to which you capture outpatient practice information, not just hospital information? And do you have any sense for what % of, outpatient practices you're actually collecting sufficient amount of data from there to be able to describe the care that they're providing? And I asked the second question is that what about the VA? There was an interaction with the VA years ago. I'm probably dead now, but it's another health system that almost all the patients are also cared for outside of the VA system, whereas collaboration there is actually important for patient well-being. So the 2 questions: outpatient and VA.
I can do the first. The first, yeah. So when we look at the system-owned practices, are all coming in through our normal feeds. So if you look at the large health systems, we are getting all of those practices that come in. When we start to get to the independent onesie twosies, really, really challenging, partly because technology capabilities, funding, whatever the source. I'm hopeful rural health transformation becomes a piece of that, where we can start to go after many of those independent practices beyond just the normal large health systems. So I'm pretty sure if you look at who is not connected from an IHIE perspective on a hospital, all of those are part of the rural health transformation program. So they would be candidates to participate beyond that as well.
One follow-up question is that most of those physicians also are part of Docs for Docs, right? So their practice AHR may not be hooked in, but if they order a laboratory test, an imaging study, that you get some information from that. Is that correct?
Yes. So all that data will feed in from an IMPC, going through IMPC, through Docs for Docs. Yes, absolutely flows in.
Hi, David Hagstrom. So I wanted to follow up on the interest that IHIE obviously has in acquiring more data. And we talked about some data categories like social determinants of health. Seeing Titus up there, I was thinking about environmental determinants of health, which is an emerging area. And in terms of the cost of acquisition for some of that type of data is pretty low because it's free, publicly available data. Now, of course, there's costs involved with the extraction, transformation, linkage, management, maintenance, updates. So I'm not saying there's no cost, but like in terms of the data that's been collected, that cost has been absorbed. So I was just interested if you could help kind of walk us through or think through what the business case is or is not for a data type to be something worth acquiring. I mean, go back to the social determinants of health example. It's something that's kind of been discussed for a decade, but not been able to do that. So what is the business case that blocks that, or that would enable one to acquire new data?
Yeah.
Take the environmental piece first. Is if I'm kind of guessing you're talking about maybe like polis things that they might have in. Yeah. The bad news is I'm not aware of any sustainable business case for that category of data on our radar screen, but may be hopeful if the data is captured and it's publicly available, could researchers hopefully combine INPC data with that data outside the INPC? Because I don't see us adding environmental data to the INPC soon. The social care stuff is a much closer and the approaches of the current state and federal administration haven't moved that forward. The FSSA, who runs Medicaid in the previous administration, so I'm not blaming anybody in the current administration, did not believe in the interventional value of social determinant data. And so lacking Medicaid's support for gathering that data, we were very much down to what would the hospital systems or other providers, what matters to them. And we were kind of going down a path with Dr. Chris Callahan and others, and that's not dead, but you may have better information on where that stands.
Just, it's slowed tremendously. I think at some point you have to have some sort of evangelist behind it, of someone that says, this is important and here's the ROI behind it. And they also have to have some sort of project that is meaningful, that they can truly accomplish. And we have different ideas working on homelessness with Dr. IHIE. We've got all these different sorts of projects that are out there. We just got to get over the hump, and we got to do one and do it well. And I think we'll start to see some momentum behind it. But we have lots of conversations, lots of details. We get up right to the point, and then we ran into challenges with data use agreements or things like that. So I think we're getting to the point where all of the different obstacles we're able to move out of the way. Funding's always going to have to play a part in it, no matter what.
I have a couple questions from the online audience. The first one is, do you view the lack of state funding as a strength or a weakness?
Both. I would say that there are certain times in which we look at that number and drive ourselves crazy because we want it to be 25%. I'm making up a number at this point. Would I like it to be 50 plus? Probably not, because when there was lots of changes with federal funding, a lot of those organizations are more concerned of trying to figure out where the next dollar comes from. And from our standpoint, having the ability to set the relationships and to build truly like a for-profit company where we say we have to provide enough value that they are willing to pay that dollar. I think that changes our dynamic a little bit. It'd be great if it was a little bit higher than 2% though.
And the second question we have is, how well characterized are the data gaps? And do you have any written resources on this?
I think that's part of the work that we're doing with Regenstrief today, is to better understand where those data gaps exist, quantify them, and then figure out a plan. We can have as much of it written down, but until we decide how we're actually going to go and accomplish completing any of the data quality components, that's a big thing, because for many healthcare organizations, this becomes another project. And so then it has to get prioritized. There has to be resources. So it's not just as easy as saying, oh yeah, you need to go get these 5 data sources. Part of it's, how do we incentivize the organizations that are sending us that data to either make changes or to send us new data elements that are not currently part of the feed.
I just wanted to add quickly on that one that even if data gaps is a more specific term than data quality. If somebody uses data quality in conversation, you really need the definition to just continue the conversation because it's so diverse. Data gaps, I just wanted to point out the one of the most important words Drew used was prioritizing, because the data gaps that a researcher might want to fill, or especially even a specific health services researcher might will have a different priority for filling a data gap than a hospital CIO versus a researcher in another space. So prioritizing what data gaps is part of that challenge.
Enjoyed the presentation. I've got two questions, one on the product side and one on the strategy rural health side. On the product side, I imagine there are endless possibilities of what AI could expand and also create a lot of heartburn around keeping up, as it's a gold rush right now, especially on the West Coast, around every tech company racing to keep up with what it can do, creates capacity prioritization. I'm curious, how are you all calibrating, like where within the core IHIE infrastructure work, as well as within its product development, where it makes sense? So that's sort of one question. And then second question is around the rural health program. Having grown up in value-based care and seeing billions of dollars very sadly spent, with most health systems in our country, very small percentages of downside risk, despite the amount of money that got pumped into health systems to move into value-based care. I'm curious 5 years from now what the outcomes that are going to matter for sustainability post the $200 billion a year for the rural health transformation. Like, which in your mind of the outcomes that the state needs to achieve are going to be most important for sustainability of money that goes into data interoperability?
Yeah, so I look to Sean very specifically because as we talk about components of AI, what makes the most sense? IHIE does not have internal resources today that have the capability, knowledge, understanding, or expertise to leverage AI in a way that we want to enhance our products. In most cases, I would say we will partner with some organization that has those capabilities, because the field is changing so rapidly that I don't want us to invest in that, because I don't think by the time we get to it, it's already changed. So I think we would need to partner with some organization. The challenge becomes what you talked about, is how deep within our portfolio we want to get. We have internal debates because, okay, there's clinical data that a clinician is going to utilize. What sort of components do we offer to ensure that it's accurate, that it's been vetted completely? I think there's a lot of that concern that we have. And so if we start, it may be, how are we going to use AI not touching clinical data, just within our own normal day-to-day work, right? And then it may be, we're going to curate some of the data, maybe option 2 or phase 2. The third phase would be some of the product kind of infrastructure, how we look at that. And I think we're still a ways down the road, but we're certainly collaborating with Sean and Regenstrief on that next step.
I wanted to, and Drew alluded to this earlier, but I wanted to add that we're working on an AI strategy and plan this year involving Regenstrief as well. That'll include 3 components. One is use of AI internally to just improve our operations. 2 is using AI in customer-facing products. And the third is supporting our customers' AI initiatives with data. And so we'll figure out what that means. But I just wanted to mention that we are going to formalize a plan on the rural health transformation. And please redirect me if I'm not answering your question. And being super honest here is I have to, on the one hand, we're just so glad the state government is actually inviting us to be in a thing, right? That I'm very focused on what do they want us to do? Because let's make sure we are very successful so that they like us and believe in the value of health information exchange, and they want us to continue to do what we do. That is not a great answer to what are the most important outcomes for rural healthcare. And so I really hope we get to inject some actual wisdom, knowledge, judgment, experience from Regenstrief and IHIE in the what should the focus be on? Where is this going to make the biggest difference? Thonkum sent a note earlier about is rural healthcare going to be an opportunity to focus on, dental health? My first answer is, well, if Medicaid doesn't care about that, then they're not going to let us. But really, how big of a factor is that if we're setting out to improve health outcomes in rural healthcare? How important is that, and is that an opportunity?
I know we're at time and I have to wrap us up here, but wanted to thank you all. This is great, really phenomenal. And one quick last question, which is for those in the room, if they're interested in talking more or learning about how they might want to collaborate or pitch an idea, what's the process by which they do that? And thank you.
Call Drew.
Yeah, happy to collaborate. And certainly you have a resource in Sean who can help direct you to the right IHIE resource because he kind of knows your space and obviously knows the IHIE space, but happy to be a conduit for any of those directly myself. Thank you.